Hello, everyone. My name is Natasha Roberts. I hope you find that learning about Lou Gehrig's disease is as interesting as I did. I did find this to be very fascinating, especially because I come from a biomedical engineering background and specialize in sports medicine, and this disease has lots of ties to that field of study. And so enjoy listening, and I can't wait to discuss with you all in the discussion board. So this slide is just about the important terminology and information so that you can understand further information on this presentation. So this slide just talks about the upper motor neuron and the lower motor neuron, and on the left it shows the neuron structure, and with normal flow of the signal, it will go from the dendrite to the axon terminal. So please pause so you can study the structure as well as read the information on this slide. So for this agenda, we'll go over Lou Gehrig disease overview, a history, patient demographics and the disease statistics, the etiology, pathophysiology, and the continuum of care, which under continuum of care, there will be the prevention, doctors, medical specialist involvement, diagnosis, treatments, and the management of the disease. So I do want to apologize before we continue if I mispronounce any words. So we're going to move on to the overview of Lou Gehrig's disease. I do want you to make note that an important date is June 21st, which is the International Awareness Day for ALS, or Lou Gehrig's disease. So amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, is a progressive nervous system disease affecting the motor neurons, both upper and lower, within the brain and spinal cord. Over time, the nerves that control voluntary muscle contraction and movement, such as breathing, walking, or chewing, weaken and become inherently useless. So almost all cases occurring, about 90% of ALS, are sporadic, which means the disease seems to occur at random with no association to family or medical history, outlining a direct prognosis. 10% of diagnoses are familial, also called inherited or genetic, where there is a link to family history, but this is very uncommon for most cases. In fact, most people with family history will not develop ALS at all in their lifetime. Since ALS is still super complicated and most of it is unknown, with new hypotheses arising every year, it is highly important to continue the work conducted within medicine research to reverse the 100% fatality that this disease brings. So kind of just going off of that, like I said before, ALS is the actual name for it, which most of us today do know it by ALS. It used to be called and more well known as Lou Gehrig's disease. Again, it is a progressive nerve system disease, and there are two forms of ALS, sporadic and familial. And this can be linked to genetic and sport medicine research, but also is linked to geriatric research. So because it's so complicated, there is so much research fields that go into learning about ALS and trying to fight against this fatal disease. Hence why this is so important to study, so that we can understand the disease etiology and the treatments or cure options that we can potentially give to these patients. If you look at the picture, this picture is the symbol for ALS. It's called the cornflower, which is the more common name for it. And a little fun facts about this flower is that it is the national flower of Germany, and Lou Gehrig, which we'll go into later in the next couple slides of history, he actually is a second generation American to German immigrants, as well as in Germany, this flower represents veterans. And a huge part of this disease is that it is veteran kind of prognosis. So like a lot of people who are veterans tend to have ALS later on in life. We don't really know why, and I'll get into more detail about that. But I just found that to be a really interesting fact about this flower. But this flower for ALS specifically is the symbol of hope because we want to give those patients something to be able to look at and know that we are trying to help them. So now let's get into the history of Lou Gehrig's disease. Just note that Lou Gehrig's disease has a long and complicated history that is both intriguing, mournful, but hopeful, as expressed through that symbolization of that flower. So in 1869, ALS was identified by French neurologist Jean-Martin Charcot. In 1874, Charcot, after observing several patients, introduced the term amyotrophic lateral sclerosis after many years of patients being diagnosed with hysteria. On June 2nd, 1941, ALS became well known internationally when Lou Gehrig, a well known beloved baseball player from New York Yankees, passed away sadly from the disease. Lou Gehrig played for the New York Yankees for 17 years, where he would become known as the Iron Horse due to several injuries he occurred over a lifespan of his career, but still went on to play the record number of 2,130 consecutive games. He became a New York Yankees baseball player in 1923 for his impeccable hitting skills and held the record for most Grand Slams until 2013 and had 493 home run stat. He became an iconic baseball player after taking the first baseman position from Wally Pipp, suffering from his famous headache. On his 36th birthday, unfortunately, Lou Gehrig was diagnosed, which was June 19th, 1939, with ALS, which unfortunately ended his career. Prior to his diagnosis, he noticed several symptoms including loss of strength, slipping, falling, and loss of coordination. On July 4, 1939, Yankee Stadium honored the baseball player for his sportsmanship and dedication to the game, and years following, known as Lou Gehrig Appreciation Day. On that day, he spoke his famous speech saying he is the luckiest person in the world. Sadly, on June 2nd, 1941, this famous baseball player, beloved by many, passed away in his Bronx home 2 years after diagnosis and exactly 16 years to the start of his famous baseball career. And on June 2nd, we call that Lou Gehrig's Day, as the Yankees wanted to celebrate him as a astonishing baseball player. And so they also used that day not only to commemorate this baseball player, but to also serve as another day to learn about ALS and to do funding for it. And Lou Gehrig, fun fact about him, he is the first baseball player for the Yankees to have his jersey retired at the stadium. So in 1993, the first gene, SOD1, was identified for familial ALS just about a decade after Sir William Osler identified patterns of ALS in the Farr family, Vermont, in 1880. In 1994, the first animal model was engineered, which was the first steps to understanding the pathogenesis and testing for treatments. In 1995, the first treatment for ALS was approved by the FDA, which was a drug called Sanofi's Riluzole. In 2000, ALS gained traction into the possible causes as well as football became known for its connection with the ALS prognosis within the community of players. In 2006, TDP-43 was identified as a major component of ALS and frontotemporal dementia, leading to the discovery of TAR-DBP being the primary cause of familial ALS. In 2011, the discovery of C9ORF72 gene defect present in ALS and FTD patients. 2014 publication indicating that 95% of TDP43 aggregation causes a loss of function protein within the nucleus. Also, what we know ALS from, the Ice Bucket Challenge, gained ALS awareness traction, which helped push further research and funding. In 2015, Japan and South Korea approved the drug adaviravon, followed by the orphan drug designation by the FDA and EU approval in 2016. In 2017, the FDA officially approved the drug for use. In 2017, a study found correlations with blue-collar workers and ALS. In 2020, the third phase of the clinical trials for oral suspension formulation for adaviravon occurred. In 2021, Biogen offers compassionate use access to their tosafersen drug, which can be seen in the picture on the right. So that concludes the history of Lou Gehrig's disease, or ALS. So now we're going to go into the disease information on Lou Gehrig's disease. And we'll be specifically talking about the patient demographic, the etiology, and the pathophysiology. So for patient demographics and disease statistics, the risk of ALS increases up to the age of 75. Most common within the age range of 60 to mid 80s, and some sources say 55 to 75, and I've seen other sources say 40 to 80. So it really just varies in the research that we can see, but it's more common analysis that it's between 60 to 80. So before the age of 65, men are slightly more at risk than women. But once they hit the age of 70, this difference kind of disappears. So white and non-Hispanics are more likely to develop the disease than any other race or ethnicity. Some studies suggest veterans are at the highest risk of developing ALS, but it's really kind of just an unclear reason. And for most of these studies, it's been an unclear reason just because ALS is a very complicated disease. Approximately 5,000 people in the US are affected by ALS, which is approximately 15 new cases a day. And that's about 20,000 at a given time can have ALS. For 10% of diagnosis, patients can be identified with genetic cause. For the other 90%, it's unknown. So it's like we said before, 10% of these patients are diagnosed with familial or genetic ALS, whereas 90% of these patients have sporadic ALS. And because this disease is so complicated and there's no cure for this, it's 100% fatal with a life expectancy average between 2 to 5 years. So some people live shorter than 2 years, some people live longer, but it's really expected you to be living 2 to 5 years after your onset first side effects. Or, yeah. So the causation of ALS is unknown, but many researchers have theorized that complex interactions between genes and factors of the environment are at the causation of the sporadic ALS, which can also be seen kind of in the familial, but it's mainly, they're mainly looking at sporadic ALS because we kind of understand a lot more about familial, and more people are affected by sporadic, so we need to start understanding that. Other risk factors that have been theorized and studied are genetics with a family history component, age, sex, smoking, environmental toxin exposure, and military service. Current ongoing research has to do with one, cellular defects with a motor neuron degeneration with some disease prevention component. And the other one is to look into adult skin and blood cell stem cell research for treatments. For those with genetic factors, which are what we consider the 10%, research is still ongoing to understand the cause of the CNORF72 mutation. For those with the genetic factor, 25 to 40% are caused by this CNORF72 mutation, which makes the proton in the neurons in the brain. So that specific CNORF72 gene is what makes protons/proteins in the neuron. And a small percentage of sporadic cases can be seen with this mutation, but it's not really, studied or well known. So 12 to 20% are caused by the mutation of the SOD1 gene, which is involved in the production of copper zinc superoxide dismutase 1. In 2021, a link most likely to the SPTLC1 gene within children 4 years of age and older may cause changes in the way the body metabolizes fatty materials, which is called lipids, was actually found, but it's still ongoing research currently. So if you look to the left at that picture, that is a picture of Stephen Hawking's, who is the longest living person reported to have ALS, which he lived about 55 years or so. So ALS is a rapidly progressive neurodegenerative disorder, which has been clinically described as dysfunction of the upper and lower motor neurons. ALS results in global onset muscle weakness. Respiratory dysfunction is characterized as terminal phase of ALS. The pathogenesis of ALS is still very unknown and misunderstood. There are 3 theories for which specialists believe is the pathophysiology of the disease. These 3 theories are dying forward hypothesis, dying back hypothesis, and independent degenerative hypothesis. The first theory, called the dying forward hypothesis, is where ALS originates at the cortical level, where the transsynaptic anterograde mechanism, which, if you don't know what the transsynaptic anterior mechanism is, it is when the nerve synapse, which is that small gap between the neurons, allows a signal to pass from one neuron to the next, where the nerve is firing information from the axon terminals in the normal direction, which is towards the other neuron, from the dendrites to the axon terminals, then from the axon terminal to the other neuron's dendrites. So with this theory, both a transsynaptic anterograde mechanism and a corticomotor-neuronal hyperexcitability, which is that cortico oh my god, can never say it. Sorry guys. Corticomotor-neuronal pathway is actually that on that left picture is that red pathway. So on that motor cortex going towards the horn cell, which is going towards that muscle. So brain, spinal cord, muscle is essentially what that pathway is. And with this, both of those features, so a hyperexcitability of that pathway, there is neuronal degeneration because there's an excessive release of glutamate, which causes cell death. So the second theory, called dying back hypothesis, is where the lower motor dysfunction occurs as a primary event for pathophysiology of ALS. This means the ALS occurs starting at the muscles or at the neuromuscular junction, where NOx affecting, which is a harmful influence or mind of behavior, that are transported backward into an axon's body, releasing toxic effect. So, like I said, dying forward hypothesis is from that brain to the muscles, whereas dying back hypothesis is from the muscles to the brain. So, whereas dying forward hypothesis looks at that upper motor neuron as the effector, dying back hypothesis looks at the lower motor neuron as the effector. So the third theory, called independent degeneration, suggests that the upper and lower motor neuron degeneration occurs independently, where the disease spread is contagious and random, conforming to the underlying neuroanatomical boundaries. So that means that this degeneration that's random is only staying within the boundaries of the motor system within that nervous system. So it's only staying between the motor cortex, that anterior horn cell, and that muscle, as you can see on that picture on the left. So kind of a little bit more about the pathophysiology. They kind of understand this part a little bit more about it, and it's kind of hypothesized, kind of not. It has some information that backs it up. Interactions between genetic and environmental factors modeled in the figure to the right seems to lead to the neuronal generation factors of ALS. So, for genetic causes, as seen in the figure to the right, the interaction between molecular and genetic pathways lead to reduction uptake of the glutamate from the synaptic cleft, leading to the glutamate toxicity, so excessive toxic functions, which is initiated by dysfunction of the amino acid transporter 2, which initiates the neurodegeneration through calcium activation. Due to the mutations of the CNORF72 and the TDB43 genes, they become fused to the sarcolemma, which dysregulated the RNA metabolism, leading to abnormalities in the translation producing intracellular neuronal aggregates. Whereas that's one of the mutations. The other mutation is the SOD1 gene, which increases the oxidative stress, which induces mitochondrial dysfunction, leading to intracellular aggregates, resulting in axonal transportation defectiveness. Since the glial cells are there to protect the neurons from damage, they start to cause pro-inflammatory cytokines and neurotoxicity release. So really, with this, they're kind of trying to see if, with randomized sporadic ALS, if it's a combination of everything, they're hypothesizing, whereas the genetic factors, it's going to be whatever genetic mutation you have and whatever path that is. A little bit into the symptoms. The symptoms can vary, and they do actually vary between patient to patient, as this is again, complicated disease. There's no exact, path for this disease. There's no exact case where every single person, gets this disease the same way. Hence why, the causes are so rapidly different. The pathophysiology is so rapidly different between patient to patient. And so symptoms vary. So in early stages of ALS, symptoms may include twitching and cramping of muscles, loss of motor control, limb use impairments, tripping and falling, dropping things, persistent fatigue, uncontrollable periods of laughing and crying, and slurred and thick speech. And that's really, like we've said before, because your muscles are weakening and you're not able to control that motor control anymore. And so in kind of some later stages, you can get trouble breathing, swallowing, and paralysis. But that is also, like I said, dependent on patient. So other symptoms may progress that haven't been listed or develop through the lifespan of the disease, but is inherently up to the patient's treatment plan and honestly the longevity of their life. So like if you're living 2 years, you're really only in that early stage where if you're living like 50 years, you're going to start getting that, breathing issues, the swallowing and the paralysis. And all patients will die from this disease. It's 100% fatal. And that's because, there's no cure. So it's 100% fatal. And we'll get in more of that in the treatments. So now we're going to get into the continuum of care for Lou Gehrig's disease, which, is the treatments, the diagnosis, how do they manage it, who's involved. So hope you enjoy. So now about the prevention. So there's no clear understanding of exact preventative measures for ALS, but what they're kind of looking into is presynaptic markings to start treatment, FTD, which stands for the frontotemporal dementia, MMI, which is mild motor impairments. For those with family history, presynaptic tracking has been well described but not been able to fully be understood in terms of preventative measures. What is needed to identify these cases is widespread sequencing and patient compliance to enroll in such research. For those with frontotemporal dementia, there is no exact preventative measure, but ongoing research is looking into exposure tracking to identify factors that cause an increased risk for ALS. For the patient population with an increased risk of ALS due to their mild motor impairment, who are diagnosed through means such as EMG, there is no current information on preventative measures, but future research and cohorts may play a vital role in the understanding this path of ALS prevention. Other research priorities are with veteran populations and populations exposed to environmental risk. And really what they're looking at is how to stop the neuronal loss. So how can we stop this degeneration of these nerves that are causing weakness of these muscles and, ending in such fatality? And really with these preventative measures, it's going to need more research because it's a fairly new study being done. So going on to the medical specialists, because it's such a complicated disease, there's so many doctors and medical specialists that go into this. I've only listed a few, but you get electrodiagnostic physicians. They're the ones, taking care of getting the EMGs done. You have the neurologists. They're the ones, diagnosing patients because, they're the specialists. Neuromuscular disease specialists, they're the ones looking at that neuron to muscle outputs and especially that EMG, and they're working with the neurologist to, figure out what your diagnosis is and really try to start your treatment plan. And then you'll see physiar, physical therapists, occupational therapists, speech therapists, nutritionists, gastroenterologists, psychiatrics, psychologists, and the list can go on. And that's just because the symptoms vary so widely and the treatment plans vary so widely. This disease is so complicated that so many doctors need to be involved and so many medical specialists needs to be involved. And that's kind of goes into like how you're keeping up and being able to kind of live longer is working with these specialists and, not just you if you have ALS, but also family members. So diagnosis can only happen when symptom onset happens. So the first time you get symptoms, but it does on average take about 9 to 12 months to diagnose it. And that's just because, like I said before, it's very complicated. But it is important to get diagnosis early on to avoid delays in treatment. There is no one way of diagnosis due to the complexity of the disease, but takes a trained specialist known as a neurologist to diagnose a patient with ALS. So there are several ways they do this. It's through EMG, NCS, needle exam, MRI, and X-ray are the most common, and the most uncommon are blood and urine tests, spinal tap, muscle biopsies. So with the EMG, they're looking at to evaluate how your nerves and your muscles are functioning. And under that, you have the nerve conduction study, which is the NCS, and they're looking at your electrical activity of your nerves and your muscles, which helps assess, deficiencies in the signal between the motor neuron and the muscle. And then needle exam detects muscle activities within the muscle fibers using a needle electrode. So the magnetic resonant imaging, which is the MRI, uses magnetic field and radio waves for a technician to take detailed imaging of the brain and the spinal cord. And they're not going to mainly use the MRI just because we don't fully understand that part of diagnostic, where we understand more of the EMG tests. The other one is X-ray, and by using invisible electromagnetic energy beams, the production of images of the internal tissue, bones, and organs can display on the film. And they're also going to use that as well, but it's really up to all of the specialists who are on the ALS patients treatment plan to work together to figure out, what's happening with this patient as well as like how to move on with treatment. Um, and other things they can do is like blood and urine tests, spinal tap, and muscle biopsies. Those are only done if the doctors and the medical specialists are like, okay, we don't really have a direct diagnosis for you, so we want to see if you have other things, and that's kind of how they rule out, you know, other ailments like muscle deficiencies that aren't due to ALS. So, notes for the treatments and the management of the disease. All treatments are for managing the disease, and there's no known cure, as the cause of the disease varied too greatly in term, making it difficult to pinpoint the specific cause. Treatments try to elongate the lifespan of the patient. There is also no known treatment to reverse the effects of damaged neurons brought on by the ALS disease. However, like I said before, treatments may slow the progression of the disease to improve quality of the life and extend survival. All treatment plans are individual, which means based upon the patient and the symptom they are feeling, they will get their own treatment plan. And this is called supportive healthcare. So currently, there are only 4 approved drugs by the FDA. Riluzole is an oral medication known for the past 25-ish years to have effects on the disease by slowing the progression down, which all of these medications essentially theoretically do that. Adaviravon is an intravenous infusion drug since 2017 and an oral drug since 2022. Sodium phenylbutyrate is an oral medication, and tofersen is an intrathecal route administration by the medical specialist and is a drug to treat patients with the SOD1 gene mutation. So if you don't have that gene mutation, you can't take that 4th drug. So with supportive healthcare, you're going to also have rehabilitation therapy, speech and communication support, support for nutrition, breathing, feeding, eating, and so on. You have mobility, speech, swallowing, counseling, and mobility care, as well as psychotherapy, ventilation, symptomatic medical treatments. So it's really looking at your symptoms and treating your symptoms to try to elongate your life. It's not to try to cure it. We can't do that with the current research that's been done. And that being said, there really needs to be more research to figure out, what can we currently do to treat ALS for patients. So this is the end of the presentation. I hope you enjoyed it as much as I did. Learning about Lou Gehrig's or ALS. It's super important just because it's so complicated and so many people are being affected and so many more people are going to be affected by it. And because we don't really know much, we need to really start researching and being able to, give back and fund, especially because, we have degrees that are able to do that. But, these are my references, and I can't wait to discuss it in the discussion with you guys. So thank you. Is